Rich, you mentioned something else about like a drug that has been tested, was evaluated, and out of it there is a small piece of data that's coming in regard to bevacizumab plus so tell us about that, like a combination of
Yeah.
TKI plus a checkpoint inhibitor.
So, there's this evolving story that altering the microenvironment changes the sensitivity to checkpoint inhibition. And while I think many of us, and certainly I'm guilty of this, we've traditionally thought about a drug like bevacizumab or ramucirumab as just working on the endothelial cells. But as science has evolved, it looks like there's more effect than that. Certainly, they only work on the endothelial cells because that's where VEGF receptor or VEGF ligand works. But there's other effects downstream from blocking the VEGF receptor. And those are things that can affect antigen-presenting cells, immune effector cells. And there's now data both with bevacizumab and atezolizumab, PD-L1 antibody, as well as lenvatinib, a VEGF plus inhibitor, with pembrolizumab in diseases outside of liver, that show that these combinations are giving response rates much higher than anticipated with either drug alone. And now that data is spilling over into liver cancer, and there's data being presented at this meeting actually with both those combinations. There's data being presented with the combination of atezolizumab and bevacizumab from a phase 1 and phase 1 expansion, as well as similar data with pembrolizumab and lenvatinib. And the IM-Brave 150 study has been launched. It's a large global randomized phase 3 study of bevacizumab and atezolizumab versus sorafenib. And that's a very exciting idea of combining now two biologics.
That's incredible. If anything, we left all the drugs barely within a year that we're able to add, and on top of it now we have all the new thoughts. It's like good that we are really so dynamically active and looking into new options as we speak. This is really incredible. So we had a great time listening to all of you. It will be nice maybe to hear like final thoughts, maybe one word or two from Dr. Kudo. Your thoughts, anything final you would like to tell us?
Yeah, but compared to the last 10 years, now we and the patients are very happy to have a choice, the option, first line, 2 drugs, and the second line, may sooner or later, four.
Three,
So
sure.
now
Maybe 4.
3, 4, and the IO will be coming, and also I'm very much expecting the combination IO plus TKI or plus IO plus local region therapy, adjuvant setting or.
I'm glad to hear about your optimism. This is great. Arndt, any final thoughts?
Yeah, so I think I can only agree that, times are really changing in the last, have changed in the last 2 years, and we have now really a lot of drugs available. We have negative data for local therapies. So it's very clear that systemic therapy will have a much more impact on the treatment in HCC in the future. And I think it's just at this point in time, and you already mentioned that we have all these interesting combinations coming. So I think at the moment the field is really moving so fast, and it's so exciting. The data Richard mentioned with the combination with lenvatinib and Avastin and combination with immunotherapy, really high response rate that we have not seen before for systemic therapy. So I think these are really exciting times, and I think we are really moving forward very fast, and we will improve survival of our patients really in the near future with these combinations.
I'm glad to hear that optimism as well, which is great. And Rich, final thoughts for you.
You said 2 words, so I would say patient selection, right? Yeah. Patient selection is very important in every intervention we do. And it has to start with the early stage patients, because again, we can have this great discussion about the exciting new systemic agents, but if the patients that are being treated by these new drugs are very sick and decompensated, they're not going to do well. And I don't think that's what we're trying to do. We're trying to select patients and triage them to the right treatments based on evidence.
Great thoughts, great thoughts. Well, if anything, thank you all for your contributions to this discussion. And on behalf of our panel, we thank you for joining us, and we hope we find the OncoLive peer exchange to be useful and informative.